Walter, for inviting me to share this topic with you all. Yeah. So it's growing wiser, living a healthy lifestyle, and matters of the heart and kidney. And from what I can see, all of us will have some heart problem or kidney problem as we grow older and older.
ஞானமான வளர்வும் நம்ம நல்ல ஹெல்த்தியாகவும் வளரணும் பற்றி பேசுகிறாரு. ஒன்று வந்து இவர் வந்து ஸ்பெஷலிஸ்ட்னாக்கா என்னன்னா சிறுநீரகத்துக்கு என்ன சொல்லுவாங்க, சிறுநீரக மருத்துவர், ஸ்பெஷலிஸ்ட் இன் கிட்னி. கிட்னின்னா என்ன தெரியல உங்களுக்கெல்லாம், தமிழில் வேறு வார்த்தை சொல்லுவாங்க கொஞ்சம் வேணாம், அம்மா வயசு சொல்ல வேணான்றாங்க. ஓகே டாக்டர்.
So actually, so this is, so if you look at it, it's a very relevant topic regarding diabetes and how patients with diabetes and will finally have some kidney problem or some heart problem, and that is why I thought this is something very relevant nowadays for everybody, whether you are at this MSF or even at the younger age group, like the young adult fellowship, because this is a real problem in Malaysia, as I will show you on the following slides. So this is, I wonder whether we can close the slides with the lights behind. Is that possible? So that will appear a bit clearer. Okay. So this is actually shows the global atlas by the International Diabetes Federation. As you can see, all the different parts of the world there, America, South America, Africa, Southeast Asia, Western Pacific, which includes Australia, New Zealand. You can see the number of patients there with diabetes. Alright, so all over the world there's 589 million people with diabetes. And if you see Southeast Asia, I think now it's a bit clearer, having the lights off. We have more than 200 patients or 170 million people with diabetes. So that's how the extent of diabetes is in the Asian Pacific region. So and if you look at the thing below, 3.4 million deaths due to diabetes. And if you look further in 2024, in every 9 seconds, one person is dying because of a diabetes-related condition. So that's very fast, very frightening, but that's the reality if you look at it all over the world. And all healthcare ministries of health all over the world are spending a lot of money because of diabetic-related problems.
ஓகே, இந்த மேப்பில் காமிக்கிறது பாருங்க, ஒரு வினாடியில் ஒன் செகண்ட் how many டாக்டர்? 1 second.
Every second then.
ஒரு 9 வினாடியில் உலகத்தில் ஒரு ஆள் சாகுறாங்க. ஆசியாவில் பார்த்தீங்கன்னா ஆப்பிரிக்காவில் பாருங்க 25 மில்லியன் இருக்காங்க, அப்படின்னா 2.5 கோடி. ஆசியாவிலும் நிறையா தான் இருக்கு. ஸோ இது வந்து சாதாரணமாக இருக்கிறது நல்ல பரபரத்துக்கு.
So that shows that animation there shows the amount of people, 170 million in South Asia, right? What?
17 கோடி சவுத் ஏஷியாவில் டயபெட்டிக்ஸில் இருக்கு.
So I'm sure you all are interested in Malaysia and what is the prevalence of diabetes in Malaysia. And if you, so actually 21% of the population in Malaysia in the adult age group got diabetes. So isn't that frightening? So 1 in 5 above the age of 30, 35, 40, 50 have diabetes. So actually I should have brought my check all of you all. That means 20% of you all will be having, 1 in 5 will be having diabetes. That's very frightening. And this is a Malaysian statistic from the Ministry of Health. Alright?
1 in 5 பேருக்கு டயபெட்டிக்ஸ் இருக்கு மலேசியாவில்.
So this also shows the statistics of the number of people, of adults above the age of 20 to 79 years old who have diabetes. As you can see, in 2000, there was just 500 or 600,000 people. In 2011, it went up to 2 million. In 2024, which is just 2 years ago, it's 4.8 million. So if you look at the population of Malaysia in 2024, it was about 30 million. So it's about 16% of the population in 2024 actually had diabetes, so very high. And in 2050, it's a projected amount 7.5 million of people in the population of say 35 or 40 million will have diabetes. So this is from the Ministry of Health Malaysia.
இது நம்ம கவர்மெண்ட் பிரகாரம் அவங்களோட வெளியீடு வந்து 2024 48 லட்சம் பேர் டயபிட்டிஸில் இருந்தாங்க மலேசியாவில். ஆனால் 2000 பாருங்க அவ்வளோ இல்லை, பாதி தான் இருந்துச்சு, காவாசி தான் இருந்துச்சு பாருங்க, காவாசி தான். 1 கோடி 1 லட்சம் கூட இல்லை, ஒரு 5 லட்சம். ஸோ வர ஏறிக்கிட்டே போகுது.
You all know about diabetes, so I'll just talk very quickly. But why I'm talking about this is because nowadays there's very specific treatment once you are diagnosed with diabetes to really treat you as a whole, not just as a diabetic patient by giving you very specific diabetic medications. Nowadays we give diabetic medications which can protect your heart and your kidney and control your diabetes well. So that's what we should all be aiming for our patients.
ஸோ இப்போ வந்து இனிப்பு நீருக்கு ரொம்ப முன்னேறிட்டோம். இந்த ட்ரீட்மெண்ட் எல்லாம் கிட்னியும் ட்ரீட் பண்ணோம், இனிப்பு நீரும் ட்ரீட் பண்ணோம். அதனால முன் வந்துடணும், பின்தங்கக்கூடாது.
So this one, the heart, kidney and metabolic conditions is something very important nowadays. And if you look at that, this one, okay, good. Okay, so the heart, you can see it just heart number of patients all over the world. This is the world data is about 60 million with actually heart failure. Diabetes, as we told earlier, more than 500 million people have diabetes. But kidney, as you all might know, there are different stages of stage 1, stage 2, stage 3, stage 4, right? Stage 5, there's 850 million patients with various degrees of kidney disease. And in Malaysia, actually, the prevalence of kidney disease is 11%. That means 1 in 10 people will have kidney disease at different stages. So that is something for us to take note. Okay? And the thing about kidney disease is it is always silent. There's no symptoms. It's only when you do a blood test, the doctor will say, oh, the kidney not very good. And all of you all will be surprised. And that is the reality. Emphasizing the importance, if you are a diabetic patient or above the age of 50, just to go routinely for a blood test, a urine test, which is very simple, can be done anywhere, just to make sure that your kidneys are fine. Okay?
ஒன்று வந்து இருதயம், கிட்னி, இன்னொன்று ஜீரண கண்டிஷன் பாருங்க. இருதயம், கிட்னி, ஜீரண கண்டிஷன். ஜீரணம்னா நம்ம சாப்பாடு எப்படி ஜீரணிக்குது பாருங்க. சாப்பாடுலேருந்து தான் நம்ம சாப்பாடு தப்பாக இருந்தால் தான் இந்த இனிப்பு நீர் வருது. அது பிரகாரம் எவ்வளோ பேர் இருக்காங்கன்னு பாருங்க. உலகத்தில் வந்து 6 கோடி இந்த HF2ன்னுவாங்க. இன்னொன்று தான் 530 மில்லியன் 53 கோடி பீப்புள் வந்து D2ன்றாங்க. இன்னொன்று வந்து அது வந்து இன்னும் உயரமானது. ஆனால் உலகத்தில் வந்து ஆக உயரம் 85 கோடி இருக்கு.
This shows patients with diabetes, type 2 diabetes, which is what majority of adults may have, and kidney disease and their mortality rates. So if you look at the first bar there, which is very low, that is shows about the 10-year mortality. That means the chance of death in a period of 10 years. So for people who have no diabetes, so some of us do not have diabetes, we're all very healthy, which is good. then we will still go. All of us have to go someday. So you still have a mortality, but it's very low. But if you have just type 2 diabetes alone, with no albumin or protein in the urine, then your mortality increases. Similarly, if you have type 2 diabetes with what we call small amounts of protein, then your mortality increases. Type 2 diabetes with a higher amount of protein in your urine, that's why the urine test is very important. Then your mortality increases, your chance of death increases. But if you have type 2 diabetes, you have protein in the urine and your kidney function not good, that means that if you did a test and it also says you confirm diabetes, you got protein in the urine, and on top of that, your kidney function is not good. Press again. And again. So your mortality increases to up to 47%. So that's the importance of why we should know that not you are diabetic. Important to know you are diabetic, but also how's your kidney function, because that will determine how well you will be. Alright?
சிறுநீர் சோதிப்பு வந்து ரொம்ப முக்கியம். அதுலேயே தான் நம்ம தெரியும், சிறுநீர் நோயில் தான் நம்மளுக்கு தெரியும் நம்ம டயபெட்டிக் இருக்கா, இனிப்பு நீர் இல்லாத. ஆனால் அது வந்து சொல்கிறது அந்த அதில் தான் காமிக்கும் உங்களோட எவ்வளோ நாள் நீங்கள் வாழலான்னு பாருங்க. அது பல விதமான டயபெட்டிக் இருக்குது. ஸோ அந்த D2 கடைசியில் இருக்குல்ல, அது இருந்தால் அது வந்து நல்லா கூட ஆயுள் இருக்கும். ஸோ வேறு இது இருக்குது. ஆனால் முக்கியம் இனிப்பு நீர் சோதனை செஞ்சு ஆகும்.
So this is about our dialysis patient. That means patients who finally have diabetes, and then they finally also may be having other associated medical problems, and then finally become a dialysis patient. So this just to show you the slide here. As you can see, diabetes, the one in orange, 52% of patients doing dialysis in Malaysia, this from our Malaysian Dialysis and Transplant Registry 2022, the cause of their kidney failure is diabetes.
52% மலேசியாவில் உள்ள வந்து இது கிட்னினால தான் இந்த டயாலிசிஸ் போகிறாங்க. அதான் மேஜர் ப்ராப்ளம். அதனால அதான் முக்கியம் பாருங்க, கிட்னி நம்ம சோதிக்கணும்.
This shows actually this slide, your life expectancy is dramatically reduced when you have type 2 diabetes and you have heart and kidney disease. So the first one is here, no diabetes, no heart disease, then you have a normal life expectancy. So the normal life expectancy in Malaysia is about 75 years for males, and for ladies about 77 years. Anybody knows why ladies live longer than men? Because the ladies give stress to men. Water agrees. But if you have diabetes, then your expectancy is reduced, your life expectancy is actually reduced by 6 years. That means instead of 75, it may just be 69. Then if you have diabetes and cardiovascular disease, it's actually reduced further by another 12 years. So you're going to go away a bit sooner. But if you have diabetes and you also have kidney disease, your life expectancy is actually reduced by 16 years. So that's a dramatic reduce. Alright, so this is something very important to know, so that when you have diabetes, you must know that you need to take care to prevent this heart and kidney problems.
மலேசியாவில் வந்து டயபெட்டிக்ஸ் இல்லாமல் இருந்தால் 75 வயசு வரைக்கும் வாழும், எவரேஜ்னு சொல்லுவாங்க. ஆனால் ஆண்கள் வந்து 75, பெண்களுக்கு வந்து 78. உங்களுக்கு ஏன் தெரியுமான்னு கேட்டார். ஆனால் ப்ரெஷர் கொடுக்குறதே பொம்பளைங்க தான், ஆண்கள் அவங்க சீக்கிரம் போயிடுறாங்க. அதனால் நீங்கள் பார்த்தீங்கன்னா 8 பொம்பளைங்க இருக்காங்க, 2 ஆண் தான் இருக்காங்க. அதே மாதிரி டயபெட்டிக்ஸ் இருந்தால் அவங்க ஆயுள் டயபெட்டிக்ஸ் வெறும் டயபெட்டிக்ஸ் 6 வருஷம் குறையும் உங்கள் ஆயுசு. டயபெட்டிக்கும் இருதய நோயாக இருந்தால் 12 வருஷம் உங்கள் ஆயுசு குறையும் பாருங்க. டைப் 2 இருந்தால் 16 வயசு 16 வருடம் குறையும். அதனால நீங்கள் யோசிக்க எவ்வளோ நாள் நீங்கள் இருக்கணும்னு. ஸோ நீடித்தனால நம்ம தான் பாதுகாத்துக்கணும்.
Like I was telling you, we're talking now about treating of diabetes more holistically with special drugs. And this is a drug. Some of you all actually might be on it already, I can imagine. It's and this has actually been available from 2015, but now actually with all the updated guidelines, it becomes very necessary if you are a diabetic patient with heart disease or kidney disease to be on it. And this shows the progression when it was just introduced in 2016 just as a diabetic drug, but now from 2016, 18, 19, 20, 21, 22, there's more and more evidence that it should be used very early because it's not only good for diabetes, but more importantly, it should be started early to protect the kidney and the heart.
மருந்து இந்த மாதிரி மருந்து ரொம்ப வந்திருக்கு. சில நேரம் என்ன செய்யறோம், நோய் இருக்குன்னு நம்ம தாமதமாக இருக்கும், இல்லை முயற்சி எடுப்போம், டெஸ்ட் பண்ண வேணாம், நம்ம லைஃப் ஸ்டைலில் மாற்றலான்னு தாமதமாக இருக்காதீங்க. எவ்வளோ சீக்கிரமாக எடுக்கிறீங்களோ அது வரைக்கும் உங்களுக்கு நல்லது உங்களோட ஹெல்த்.
Yeah. So this is the paper, the medical paper in the journal that was produced to show that this particular drug that I told you of, which some of you might be on it already, known as empagliflozin, or the drugs that they have in the government hospital is known as Jardiance or Dapiga or Forfija, which by being on it, we can reduce the mortality or death in patients with diabetes.
இந்த மாதிரி மருந்து இதை தான் ரொம்ப இந்த மாதிரி மருந்து இருக்கு. இதை நீங்க எடுத்தா உங்க ஆயுள் கூட இருக்கும், கூட நாள் வாழலாம். கூட நாள் வாழ ஆசை இருந்தா நீங்க மருந்து எடுக்கணும். இல்லைன்னு நம்ம சும்மா மறந்துக்கிட்டு இருந்தா அது நம்மளுக்கு தான் பாதிக்கும்.
So this is the results of the trial that shows that with taking this particular medication on top of your usual medication for diabetes, reduce the cardiovascular death, can reduce heart failure, can reduce heart failure and cardiovascular death or hospitalization due to heart failure, and you can also improve the kidney outcomes.
இப்போ மருந்து கலந்து கொடுக்குறாங்க. கலந்து கொடுக்குறோன்னு நம்ம எவ்வளோ பிரச்சனை மாட்டாமல் இருக்கிறதுக்கு இதுதான் நல்லது பாருங்க. ஸோ அதை காமிக்குது. நீங்கள் சீக்கிரம் எடுத்துகிட்டு இந்த பிரச்சனையை நம்ம தாமதமாக இருக்கக்கூடாது, சீக்கிரம் மருந்து எடுத்துக்கணும். ஆனால் இதெல்லாம் புது மருந்து.
Yeah. So this is also something that I very importantly want to show you all. This actually shows the graph. So the one in red is the standard medications that are being given to patients, but the one in blue is the new medication that we actually like to give to our patient. But if you follow the graph, that initial part there's a drop in your kidney function. So here I'm telling you, be on the drug, but initially there's a drop in your kidney function. But that is a noted thing. But if you follow the patients over 12 months, 24, 36 months, then the kidney function stabilizes and improves compared to if you are not on the drug. Okay? So that's something important for you all to know. So although there's an initial drop in your kidney function, in the long term, the kidney function becomes stable and is better, as you can see in the follow-up of the patient up to 36 months. Alright?
ரெண்டு மாதிரி மருந்து இருக்கு. அந்த சிவப்பு லைன்ல காமிக்கிறாங்கள அது சாதாரண மருந்து, சாதாரண ஹாஸ்பிட்டல்லாம் கிடைக்கும். இந்த நீளம் புது மருந்து. புது மருந்து எடுத்தாக்க துவக்கத்துல அவ்வளோ நல்லா இருக்காது பார்க்க, ஆனால் நாள் போக அதுதான் உதவும். அந்த புது மருந்து. பழைய மருந்து காமிக்குது நேரிட்டு இறங்கும் பாருங்க. ஆனால் அந்த புது மருந்து தான் நம்மளை இன்னும் பாதுகாக்கும். துவக்கத்தில் பயமா இருக்கும், டாக்டர் வேற மாதிரி சொல்லுவாங்க, அப்புறம் நல்லா இருக்கும். அதுதான் நல்லது.
So this is a very important projected thing that if you take this drug, you can actually, if you start it early, that's why nowadays we want to treat our patients early with this drug, you can actually prevent the kidney disease progressing by from the patient that means becoming a kidney disease or kidney failure patient. If you start the drug very much earlier, so the x-axis or the y-axis there, if you start it early, you can even prevent the patient from becoming a kidney disease patient by 26 years. But if you start it late, there's still some hope, but it's just by 2 years. So this graph basically is a projected graph telling that if you start the drugs early, you can save the patient from becoming a kidney patient, kidney disease patient.
இந்த மருந்து சீக்கிரம் எடுத்துட்டா நம்ம சிறுநீர் பாதிக்காது, சிறுநீரகம் பாதிக்காது. அதுதான் சீக்கிரம் தாமதம் பண்ணால் அது பாதிச்சிடும். ஸோ நாளாக நம்மளுக்கு தான் பாதிப்பு. அதனால் தாமதம்னா சீக்கிரம் எடுத்துடணும், காத்திருக்க வேண்டாம். ரொம்ப பேர் பயப்படுவாங்க, ஏன் மருந்து நான் சொன்னேன் நம்ம அதை மருந்து ஏன் எடுக்கணும், மருந்து எல்லாமே நம்ம மாற்றி பார்க்குறேன், முடியாது. ஸோ அதனால் சீக்கிரம் முடியலைன்னா செஞ்சிருக்க சீக்கிரம்.
So basically this graph also is basically the same thing, this is just in table form. Yeah. So if you start the drug when your kidney function is fairly good, then you can save the patient from becoming a dialysis patient by 38 years. You know, but if you start it later, then you still save the patient, but the ability to be useful to the patient is much less. Yeah.
சீக்கிரம் செஞ்சுன்னா டயாலிசிஸ் போக வேணாம் பாருங்க. 38 வயசு நீங்கள் 37 வயசு காப்பாற்றலாம், இல்லைனாக்கா 17 வருஷம் நீங்கள் தான் எடுக்கணும் பாருங்க. ஸோ நீங்கள் சீக்கிரம் செஞ்சுட்டாக்க அந்த டயாலிசிஸ் தான் அதான் வேதனை பாருங்க, நீங்கள் அதுக்கு போகாமல் இருக்கணும், அதுதான் முக்கியம்.
If you saw that amount there, 756,000, just because we have saved the patient from becoming a dialysis patient by 38 minus 70, that's already almost 21 years. Then you can save this amount of money, 700 over 1,000. But if you started the drug later, you still save the patient by 14 years and you can save 500,000. But if you start it late, you still save money, but only 72,000. So just telling that if you actually finally end up being a kidney disease or kidney failure patient, amount of money that either the government has to spend or you have to spend is this amount. So the importance of why we start this drug early. Alright.
சீக்கிரம்
Okay. Yeah. So this is actually relation showing this table or this chart here shows actually if you have hypertension, you have diabetes, you know, and then you also have cholesterol, then being overweight, then you may have some associated liver disease, and these are the patients finally become patients with kidney and heart disease. So they are all related in this chart here. So nowadays when we look at patients, we just don't look at it in a very separate manner. Yeah, oh, you're a diabetic patient, oh, you're a kidney patient, oh, you're a heart patient. It's all related. So that's what's important for us to know as doctors, as health professionals, and also for the patient to know. You're just not a heart patient, you're just not a heart kidney patient. You are actually a patient with diabetes with heart and kidney condition.
இது நீங்கள் பாதுகாக்கலைனாக்கா சொல்லணும், நம்ம சொன்னீங்க இனிப்பு நீர் இருக்குது, இருத நோய் இருக்குது, அப்படி இல்லை. இதுலேருந்து வேற நோயும் வரும் பாருங்க. இந்த ஒரு அங்கத்தை நம்ம பாதுகாக்கலைன்னா கிட்னியை பாதிக்கும், ஈரலை பாதிக்கும், கடைசியில் குழப்பமாயிடும். டாக்டருங்களுக்கு என்ன செய்யறதுன்னு தெரியாது. அதனால நம்ம தான் எந்த இதுனா அதை பாதுகாத்துக்கணும்.
So this slide actually basically shows, like what I said before, if your kidney function deteriorates or you do not have protein in the urine, but more later on you have small amounts of protein, so then A1, A2 or big amounts of protein in the urine, then your mortality increases. So that means has the protein in the urine. So urine test just very simple, doesn't cost much, but just presence of protein and the amount of protein in the urine, as it increases, then the hazard ratio, that means your mortality increases. Similarly, if your kidney function is deteriorating, then once again your mortality increases. So this is this graph here.
So your protein increases, your mortality better.
Mortality is better.
அதான் இனிப்பு நீர் இதில் நம்ம சிறுநீரை நம்ம சோதிக்கும் பொழுது சீனிக்கு மட்டும் இல்லை ப்ரோட்டீனுக்கும் பார்ப்பாங்க. ஸோ அந்த ப்ரோட்டீன் வந்து கூட இருந்தால் நம்மளோட ஆயுள் குறையும். அதனால அதுவும் பார்க்கணும் பாருங்க. சீனி மட்டும் இல்லை, ப்ரோட்டீனும் டெஸ்ட் பண்ணுவாங்க.
So basically, if you can take a break here, just here, and what we have seen so far. So I think it's very clear, being a patient with diabetes, we actually now have to really consider seriously when is our heart going to be affected, when is our kidney going to be affected, and we take care of it so that we can prevent this complication. Right? Any questions at this stage?
ஏதோ கேள்வி இருக்கா? கேள்வி எதுவும்?
Oh, okay. Huh? Sorry? What about it? I'll just answer this question after that, no more.
Good question.
Good enough question. Yeah. So actually that's a very important question. Your kidney is leaking protein because the kidney function is bad. So that's the reason. It's not because you are eating protein. But at different stages of kidney failure, that's why you want to know whether your kidney disease stage 1, 2, 3, 4 or 5. Then your doctor, your kidney doctor or your physician will advise you about the amount of protein that you have to take. So if your diabetes is, you do not have kidney disease at all, then the doctor will tell that your protein intake should be normal. But if your kidney disease progresses, especially when it goes to stage 3, 4, 5, then the doctor will actually tell you to cut down the amount of protein intake. Because the higher the amount of protein intake, your kidney is still very good. You know, it will still be functioning, but it has to work harder. When it works harder at that stage of kidney disease, then in time to come, it will deteriorate its function. So that's the concept that you have to realize. Alright?
அம்மா கேள்வி கேட்டாங்க. இந்த மாதிரி டாக்டர் சொல்கிறாங்க ரொம்ப ப்ரோட்டீன் சாப்பிட்ணும், அப்போ தான் மசில்லாம் நம்ம இதெல்லாம் பலமாகும் டாக்டர் சொல்கிறாங்களே. ஆனால் நீங்கள் ஏன் யூரினில் ப்ரோட்டீன் ரொம்ப இருந்தால் பாதிக்குதுன்னு பாதிக்குது இல்லை. கிட்னி பிரச்சனை இருந்தால் அந்த ப்ரோட்டீன் வந்து வெளியாகுது. ஸோ அதனால தான் வெளியாகின உடனே அதுதான் பாதிக்குது, வேற ஒன்றும் இல்லை. கிட்னி நல்லா இருந்தால் அது இல்லை. ஸோ அதனால கிட்னியை பாதுகாத்தா தான் அந்த ப்ரோட்டீன் வெளியாகும்.
So this shows the burden of kidney disease in Malaysia. So the prevalence, that means the amount of patients in the whole country on adult population in 2011 was 9.1%. But in 2018, that is almost 6 or 8 years ago, it was 15%. So the amount of kidney disease, not kidney failure, kidney disease, that means different stages of kidney disease. And as you can see in the graph there on your right hand side, it shows the percentage of patients increase from 2011 to 2018. You know, there's a 67% increase of patients requiring dialysis in Malaysia during that short period of 2011 to 2018. So that's the burden of kidney disease in Malaysia.
2011 தான் இருந்துச்சு. அப்புறம் அந்த 7 வருஷத்தை பாருங்க 15% ஆயிடுச்சு. ஏன்னாக்கா அதனால தான் பார்க்கணும் நம்மளோட லைஃப் ஸ்டைல் மாறுறதுனால அது எப்படி நீங்கள் பாதுகாக்க போகிறீங்க. ரொம்ப வேகமாக ஏறுது, நாள் ஆக ஏறிக்கிட்டே போகுது. ஏன் நம்ம தெரியணும் பாருங்க. ஸோ அதனால இது வந்து ரொம்ப சிக்கடி அது கிட்னியோட வியாதி. அதான் நம்ம பாருங்க ரொம்ப டேஞ்சராக இருக்குது.
This just to compare with the United States, this is showing in 2005, and then the last one is 2017, 2020. So their prevalence of kidney disease is also 14%. So we are just the same. In fact, we are slightly higher than the United States. So that's something for us to take note of. Alright.
அமெரிக்காவில் பாருங்க எவ்வளோ இருக்குன்னு. ஆனால் மலேசியாவில் கூட இன்னும் புரியுது. அவங்களோட நம்மளோட இதெல்லாம் கொஞ்சம் கூட சின்ன நாடாக இருந்தாலும் ஹையர் தென் அமெரிக்கா பெர்சென்ட். ஸோ நம்ம அமெரிக்காவோட கூட இருக்கும் இன்னும் புரியுது.
So this one is actually the projected increase of end-stage kidney disease in Malaysia in 2040, and as you can see, as the years have gone up, the projected increase is really going up significantly. So that is something a worrying trend. And this is the percentage of patients in the population also currently 1993 to 2013, and projected to 24. We're going to have the prevalence. I told you we are having actually currently about 50,000 patients on dialysis, but by 2040 it is projected to be more than 100,000. So which is a very worrying trend. So something for us to take note. Right? 2040 we have more than 100,000.
இப்போ வந்து 40,000 ஆகும். 50 இப்போ வந்து 50,000 பேர் இருக்காங்க டயாலிசிஸ் மலேசியாவில். ஆனால் 240க்குள்ள 1,00,000 பேர் வந்துடுவாங்க. ஸோ அப்போ பாருங்கள் இவ்வளோ பாதிக்கிறாங்க.
This is also data from the United States Renal Registry, but all the countries contribute to it. And if you see the one there, can you see? The one in red is Malaysia. So Malaysia is actually the country with the highest percentage is written there right at top. It's Brunei Darul Islam, the country with the highest rate of new treated end-stage renal patients by country. So the highest country there on the top is Brunei, but we are not very far away. Malaysia, we are actually number 6 in the world, and this because all of us contribute to the data by this registry, you know. But as you can see, Singapore always wants to be better than us, so they are number 3. Okay? We are number 6, Brunei is number 1, and Singapore always wants to be better than us, they are number 3. Okay? So that's not good. These are not very good, right? Okay.
மலேசியாவில் வந்து 6வது இடத்துல இருக்குது உலகத்தில் டயபெட்டிக்ஸில் பாப்புலேஷன் பிரகாரம். சிங்கப்பூர் 3ஆம் நம்பர் இருக்குது. அவங்க நம்மளுக்கு எப்பயும் முன்னே தான் இருக்காங்க. ஸோ அவங்க நம்மளோட இன்னும் மேலே இருக்காங்க. அது நல்லது இல்லை. பட் நம்ம 6வது இடத்துல இருக்கோம் உலகத்தில்.
So this also shows where Malaysia is about the percentage of patients treated due to why the percentage of patients due to diabetes end up in kidney failure. So Malaysia is still high in the list, number 5 in the list, but the top on the list is actually Brunei, right? So all the patients being treated for kidney failure, why? The majority in Malaysia is diabetes, but even in Brunei is even higher. So this one actually shows this graph just basically shows different countries, and Malaysia is still there. You can see at the end there, the percentage of patients requiring dialysis over time. So in Malaysia, so it has that's the one there, the red. Okay. So this shows the rate of kidney transplant. So as you know, when you have kidney failure, you can be treated by dialysis, either hemodialysis or peritoneal dialysis, or you can have kidney transplant. So the best option is actually kidney transplant. But if you look at the rate of transplant in Malaysia is very low. So Malaysia is literally at the bottom of the list. So this is not good to be at the bottom of the list. This by right we should be on the top of the list. But Malaysia is very poor. That means the chance of getting a kidney transplant in Malaysia is very low. So that's not good.
மலேசியாவில் வந்து இந்த ஒன்று வந்து மறந்து இன்னொன்று வந்து கடைசியில் வந்து கிட்னி மாற்றுறது மாதிரி ஹார்ட் டிரான்ஸ்பிளான்ட் மாதிரி. அதனால் கிட்னி டிரான்ஸ்பிளான்ட் வந்து மலேசியாவில் ரொம்ப குறவாக இருக்குது. வேணும்னா சொல்லுங்க, நான் 10 லட்சம் 20 லட்சம் நான் கிட்னி கொடுக்குறேன்.
So very important. We'll ask just one question. Anybody knows why the kidney transplant rate in Malaysia is very low? Actually, the main thing is people should actually be willing to donate their kidneys while they are alive. That means your loved ones, if your loved ones have kidney disease, or you can actually pledge your organs for kidney transplant. So in the event of a death, say due to an accident, then you should pledge your organs so that your organs can be used for kidney transplant. But of course, your family must be aware of it. That is, by the way, okay? Yeah. I think we can go to the next one. The next slide. So this is actually from our own registry data, and you see the number of new dialysis patients in 2024, 2025 there's only 8,000, and now in 2024 there's more than 9,000 patients. Yeah. Okay, and then the next slide. So yeah, this is the total number of patients. So in 2015 there was just 37,000. Now in 2024 there's 55,000.
டயாலிசிஸ் பேஷண்ட் ஓகே 2024 பாருங்க 52,000 பேர் இருக்காங்க. ஆனால் 2015 பாருங்க 37 தான் பாருங்க. அந்த 9 வருஷத்துல 10,000 பேர் ஏறி இருக்கு. 10,000 பேர் ஏறி இருக்காங்க அந்த அமௌண்ட் பாருங்க.
And this is looking at the cause of death due to on patients on dialysis. So why do patients on dialysis die? See, actually the top on the list there is actually due to heart disease, cardiovascular death. So that is why. So I told you the most important cause of kidney failure in Malaysia is diabetes, and the most important cause of death in patients finally with dialysis is also heart disease. So they're all related. It's all interlinked. So we should not be treating this all separately, right?
கிட்னினாலேயே பாருங்க எவ்வளோ பேர் இருதய நோய் மாரடைப்பு இருதய நோயோட மறக்கிறாங்க. ஸோ கிட்னி நோய் வந்து நம்ம இருதயத்தை பாதிக்குது. அதனால இதுதான் முக்கியத்துவம், நம்ம இதுக்கு முக்கியத்துவம் கொடுக்கணும்.
So who are the patients who will develop kidney disease? So, most important, you all know, diabetes, hypertension patients. Then those with recurrent urinary tract infection. So if you develop urinary tract infection, it's okay. But if your urinary tract infection is every 2-3 months you're getting urinary tract infection, every 2-3 months you're getting, then you better be worried. Or you have kidney stones. And those who patients who just young patients, maybe they have what is called inflammation of the kidney, glomerulonephritis. All this condition known as SLE, systemic lupus erythematosus, is also a cause of kidney disease. Patients who have been admitted to the hospital and your kidney function actually deteriorated temporarily. You may not have required dialysis or may have required dialysis and you have recovered. But these patients have to be on long-term follow-up because these are the very patients who can become kidney disease patients or end-stage kidney failure patients in the future. Those who are overweight, actually being overweight is a risk factor for so many things, including kidney disease. If you have a family history of kidney disease, any member of your family got kidney disease, can be inherited, may not be inherited, you have to be extra careful. And the last but not least will be those with heart disease. So heart disease will also result in kidney disease. So when patients have all these risk factors, diabetes, hypertension, infection in the urine, stones in the urine, kidney disease due to inflammation, past history of acute deterioration in kidney function, being obese, having a family history of kidney disease, and if they have a heart problem, these are the patients at risk of becoming chronic kidney disease patients and then finally becoming kidney failure patients.
கிட்னி நோய் ஏன் போய் நம்ம கிட்னி நோயில் ஏன் வந்து நம்ம விழுறோம்னா, ஒன்று வந்து டயபிட்டிஸ், இனிப்பு நீர், இன்னொன்று வந்து ஹைப்பர் டென்ஷன் வாங்க, ஹை பிளட் ப்ரெஷர். அதே மாதிரி குடும்ப வரலாறும் இருக்குது. குடும்ப வரலாறு பழைய உங்கள் தாய் தாத்தா பாட்டிக்கு இருந்தாலும் அதுக்கும் நம்மளுக்கு பாதிக்கப்படும் வரலாறு பிரகாரம். இன்னொன்று வந்து அந்த ரொம்ப சாப்பிட்றது, கட்டுப்படுத்துறது இல்லை, வாயை கட்டுப்படுத்தாமல் இருந்து அது என்ன உள்ளுக்கு எடுத்து வெளியே வரப்படுது, இந்த நோயில் போய் வருதுட்டாங்க. ஸோ சாப்பாடு கட்டுப்படுத்தணும். இன்னொன்று வந்து நம்மளோட வெயிட்டை பார்க்கணும், பெருசாக இருக்குமா சிறுசாக அது உடம்பை பாதுகாத்துக்கணும். பாருங்க, ரொம்ப பெருசாக இருந்தால் கஷ்டம் தான். அதனால தான் எக்ஸசைஸ் பண்ணணுன்றாங்க, ரொம்ப முக்கியம்.
I think John Nehru interpreting more than what I said. So these are just very quickly studies I want to just show you to show that actually these studies were done in the early 2000s, and with that we were able to reduce kidney disease. But in spite of that, the kidney disease is still progressing. Then earlier I was talking to you about drugs known as SGLT2 inhibitors, which I said some of you all may be on, like Jardiance, Forxiga, Dapiga. So these were these studies that show that we can even reduce the risk of our patient going kidney disease further. And the last slide there on your right hand side at the top there, this shows that we can actually reduce, by putting these patients on these particular drugs, we can reduce the incidence of kidney disease or patients progressing to kidney disease.
கிட்னி நோய் எவ்வளோ மருந்து புதுசு கண்டுபிடிச்சாலும் ஏறிக்கிட்டே தான் போகுது. அதனால நம்ம வந்து தான் முயற்சி எடுத்து அந்த மருந்து வந்து ரொம்ப பாதுகாப்போம். ஆக்சுவலி அந்த மருந்து நம்ம சாப்பிட்டாக்கா கண்ட்ரோல் பண்ணிடலாம், நம்ம சொந்தமாக பாதுகாத்துக்கலாம். அதனால இந்த புது மருந்து வந்து இருக்கு, அந்த மருந்து வந்து நம்ம சாப்பிட்டா நம்மளுக்கு தான் பாதுகாப்போம். So
this is another new drug which some of you all may not be on, which is very important, and this drug is known as semaglutide. which can actually prevent the patient from going into kidney disease. Yeah. Next slide. Yeah, and this slide basically shows that by starting this patient on these drugs which I just told you, known as semaglutide or liraglutide, we can prevent the patient from going into kidney disease, and it is effective at different stages of kidney disease. Yeah, so this slide just confirms it now. In patients with type 2 diabetes with underlying kidney disease, you start the drug on the dark blue side, you can prevent the patient from progressing to kidney disease. They still progress, but the rate in which they progress to kidney disease is much reduced. So we do not have a drug which can actually reverse the kidney function, but we definitely have drugs nowadays to slow down the progression of kidney disease.
So இந்த புது மருந்து வந்து பாருங்க சாப்பிட்டாக்கா நம்மளுக்கு இது குறையும் கிட்னி நோய் இல்லை கிட்னி நோய் தான் பற்றி பேசணும் பாருங்க. ஸோ கிட்னி நோய் அது நம்ம தடுக்கிறதுக்கு இந்த புது மருந்து சாப்பிட்டா ரொம்ப உதவுது. அதான் அந்த புது மருந்து அந்த செமகுலோடைட்ன்றாங்க. அதை நீங்கள் டாக்டர் அப்புறம் மேலே கொடுப்பாரு.
So this is just a summary again of all the studies available, all the drugs available at different groups which can prevent us from becoming a kidney disease patient and can reduce heart mortality or kidney mortality. That means problems due to the kidney or heart can be by taking this group of drugs.
ஸோ இந்த மருந்தெல்லாம் சாப்பிட்டா நம்மளோட கிட்னி நோய்களையும் நம்ம பாதுகாத்துக்கலாம். இருதய நோய் ஏன்னா கிட்னிலேருந்து தான் இருதய நோய்க்கும் போது பாருங்க. ஸோ அதனால கிட்னி நம்ம பாதுகாத்தா இருதய நோய் நம்ம பாதுகாப்பாக இருக்கணும்.
So this is one of my last few slides. So it's key medical highlights. So what have we talked about? We talked about patients with type 2 diabetes, with chronic kidney disease, and by groups as this one. Yeah, by treating them accordingly, we can actually prevent our patients from becoming patients with diabetes from becoming a kidney disease patient to start with, and even at different stages, whether it is stage 1, 2, 3, 4, 5. But we can also prevent, when we treat the diabetes also with this kidney in mind and the heart in mind, we can even prevent them from becoming a heart patient. But whatever it is, whatever you do right up to now, we can, and we see by using these drugs, we have actually nowadays seen less and less patients actually progressing. You know, last time when we see the patients every 3 months, every 6 months, then after 9 months, 1 year, we see that kidney disease progressing, and we are already telling our patients, it's time, prepare now for dialysis. But now I'm seeing the patients after 1 month, 3 months, 6 months, starting with medications or these drugs that are available, which are also available in the hospitals, including the government hospitals, the Klinik Kesihatan, and say IGN, or those like John Nehru, who's very rich, and goes to the private hospital. Then these drugs are available, and by right you should be on it. And if you're not on it, then you have to wonder why you're not on it. You know, and so as patients, you know, we should actually be aware that these drugs are available, and if you're not on it, just have a friendly chat with your healthcare professional, your doctor, and then there are certain patients that we will not use, so that even I have all these drugs available in my hospital, but not each and every patient is on it. Some patients may, if they are killed too late, you know, they are already nearing kidney failure. You know, we actually have patients coming because they want a second opinion. The doctors have, say in the government hospital or another private hospital, have told them you have to prepare for dialysis. Then they come to us. You know, they want us to, oh doctor, I heard you got new drugs now to prevent me from becoming a dialysis patient. But if it is too late, you cannot do that. You know, but if you start it early, like what I showed you all, then you can actually prevent. And from what I can see in my practice over the last 20-30 years, that nowadays the patients are coming up and the kidney function is remaining stable, which is very good. Right? Having some technical issues, but maybe John can.
இந்த மருந்து சாப்பிட்றப்ப ரொம்ப நீட்டா பேசிட்டாரு. ஸோ கிட்னி நோய்க்கு இப்போ இந்த மருந்து சாப்பிட்டாக்க முன்ன வந்து மருந்து சாப்பிட்டா 3 மாதத்துக்கு போய் பார்ப்பீங்க, 6 மாதம் போய் டாக்டர் பார்ப்பீங்க. அப்போ வந்து நோய் இன்னும் கூடக்கிட்டே போகும் பாருங்க. ஸோ கடைசியில் என்ன சொல்லுவாங்க, 6 மாதம் 2 வருஷம் சொல்லி நீங்கள் டயாலிசிஸில் போயிடணும். இப்போ வந்து நீங்கள் அந்த மருந்து சாப்பிட்டா அது டயாலிசிஸ்க்கு போக வேண்டியது. ஏன்னா அது வந்து இந்த நம்ம பொறுப்பாக இந்த புது மருந்தை சாப்பிட்டாக்கா அதெல்லாம் இருக்கிற மருந்து கவர்மெண்ட் ஹாஸ்பிட்டல் கிடைக்கணும். அதை நீங்கள் சாப்பிட்டா டயாலிசிஸ் வரைக்கும் போக வேண்டியது. ஆனால் ஏன் அந்த வேதனைக்கு போனாங்கன்னா அது வந்து தள்ளி கொண்டுக்கிட்டே போகலாம். முன்ன வந்து இல்லை, முன்ன வந்து 6 மாதம் 3-4 வருஷத்துல டயாலிசிஸில் போயிடுவாங்க. ஸோ இப்போ வந்து நம்ம மருந்தை சாப்பிட்டா அது நம்ம எல்லாம் ரொம்ப மருந்தெல்லாம் இருக்குது நம்ம பாதுகாப்பு.
Telling Johnson said there's a slight technical issue, but I had a talk with him. I think he's trying to boycott me. He's trying to say that I talk too much. But in basically, that's the conclusion. You know, so kidney disease is harmful. Kidney disease is treatable, and kidney disease is preventable. So all of you all should know that. And your kidney and your heart are definitely very, very much related. And because of that, to take action so that we can prevent you all from becoming a kidney disease patient. With that, thank you.
என்ன சொல்றாங்க, இருதயமும் கிட்னியும் சம்மந்தப்பட்டது தான் பாருங்க. கிட்னினால ஹார்ட் பாதிக்கும், ஹார்ட் பாதித்த நம்மளோட வாழ்க்கை நடைமுறை எல்லாம் மாறிடும் பாருங்க. ஸோ அதனால கிட்னிக்கும் ஹார்ட்டுக்கும் தொடர்பு இருக்கு. அதனால கிட்னி வந்து நீங்கள் முதல்ல பாதுகாப்பு சாப்பாடு முறையில் வேற வேறு மருந்து சீக்கிரம் எடுத்துருங்க, தாமதிக்காதுங்க.
With that, thank you. Doctor, we're still trying to get the thing because there's some questions for you all to answer. You know, but while we're waiting for the thing to come up, yeah, you all got any questions?
Yes, please, Doctor. What do you think of the new drug Ozempic?
Oh, very good. Very relevant question. That's what I showed actually. You know, so the last few slides that I showed the drug known as semaglutide, that is actually Ozempic. So Ozempic is just the trade name, but the content of it is semaglutide. So actually semaglutide has been proven in a trial, which I showed you all, that slides showing the graph and all, by the flow trial, we actually can slow down the progression of kidney disease. You know, so it is a good drug, and if your kidney function is not bad, and you see the doctor earlier enough, so the doctor will most of all have to look, are you on the earlier drugs available, which has been there from the year 2000 already, like captopril or enalapril, you know, or losartan that some of you all may be on. Then they will start on the other group of drugs known as Jardiance or Forxiga or Napilam, which is also available now. Maybe some of you all may be on it. But the other drug to start will be is Ozempic. You know, so the doctor will look at your progression. If it is still not good enough, then it is actually correct to put you on this drug. Very good question. Any other questions from the floor?
Just now you mentioned about enalapril.
Yeah.
Oh.
Yeah. So enalapril is a very good drug. It's been available for a very long time already, from the year 2000 plus or even 1998 already available. You know, so it's belong to a group of drugs known as ACE or ARBs. So because of it, it has been shown along with other drugs in the same group to protect the patient from progressing into kidney disease. Right? Yeah. So if you are having hypertension, it's a good drug to be on. If you have underlying diabetes, it's also a good drug to be on to prevent you from progressing to become a heart or a kidney patient. Right? Yes?
These drugs has to be recommended by the doctor first before you take, or you
Sorry?
just buy the pharmacy and take the drug.
Oh, okay. Yeah, that's a very relevant question. You know, so now that we actually want to empower our patients to have the knowledge of what drugs they should be on. So what asked is whether you can just go and now buy the drugs over the pharmacy. The answer is yes, but you can buy the drugs, but I wouldn't do that. I would start it along with the doctor. So it can be, you don't necessarily have to see a specialist. A lot of nowadays there are what we call primary care physicians. So if you go to University Hospital, they have a Buka clinic, you know, where they follow up with patients with diabetes, hypertension. You even go to the clinic Kesihatan, you know, and I'm actually very impressed nowadays. You know, they start the patient with this drug and including another drug known as Dabiga, which is actually the generic version of the original drug. But you know, so patients come to see me because they are, the doctor has said, oh, you already got kidney disease, so they're worried, so they come and see me. But when I see the drugs started, so apart from drugs like Enalapril or Losartan, then they have also started with drugs known as Dabiga or Forxiga or Jardiance, you know, and then so when we see the drugs and then we follow up the patients, like I said, in real life they are actually not progressing. So nowadays we've got a lot of good drugs that you should be on, along with your doctor to monitor you, and because there are certain times in your care or your health, your life, the doctor says, oh, temporarily now you have to stop this drug because you're having an infection, example. You're admitted to hospital with respiratory tract infection or urinary tract infection or suddenly have heart failure. Certain drugs the doctor will temporarily stop it. Then the doctor needs to restart it again. So that is why you should always start the drugs in concordance with the doctor monitoring you. Don't just buy it over the counter.
அம்மா கேட்ட கேள்வி வந்து இந்த மாதிரி மருந்தெல்லாம் நம்ம சொந்தமாக போய் ஃபார்மசியில் வாங்கி சொந்தமாக எடுத்துக்கலாமான்னு கேட்டாங்க. அதுக்கு டாக்டர் சொன்னாங்க வாங்கலாம், எங்கேயும் கிடைக்கும். ஆனால் டாக்டரோட அபிப்பிராயம் ரொம்ப நல்லது, முக்கியம். இல்லைன்னா நம்ம அவங்களுக்கு தான் நம்மளோட எவ்வளோ பாதிக்கப்பட்டிருக்கோம், எவ்வளோ முன்னேறி இருக்கோம் எல்லாம் அவங்களுக்கு தெரியும் பாருங்க. அதனால அது பிரகாரம் டாக்டர் மருத்துவர்கிட்ட போனால் நல்லது.
I think there's a Dabiga.
Sorry?
The Dabiga hour.
Yes,
I
correct.
take that once a day.
Very good. I told you, see, there's very good care actually now by the government hospital clinics, you know. So, yeah, IT was asked me privately earlier before my talk how she can prevent herself from becoming a kidney disease patient. So, of course, got a free consultation there. Ask Walter to send me the bill. But the most important thing is, so now she's on a drug known as Dabiga, which is actually proven to actually prevent the kidney disease from progressing. So probably she's also another drug. She told me she was on a cholesterol medication, you know, to protect the heart and also the kidney finally, you know. And then I'm sure you are also an ACE inhibitor because of your underlying diabetes, hypertension, and certain other medications for your diabetes. You know, so probably you're already on at least 2 or 3 medications to can protect the kidney. So should you be on like what the auntie said on Ozempic to protect the kidney further, that you need to talk to your doctor.
When I check, it's only 5.4 or something. My
Sugars.
Sugar.
Yeah.
It's under control.
So it has a dual effect. It helps to protect, it helps to control your diabetes, and it also protects the kidney and heart. Right? So it's a good medication to be on. Okay, so this Akash here is asking about the medication known as Jardiance. So Jardiance actually belong to the same group of drug as Dabiga. You know, it's from a different company, of course. You know, but one of the studies that I showed you earlier, that's the drug. So if you're on Jardiance, are you on Jardiance? No, what's it? Oh, your husband is on a very good drug, which actually protects the. It helps. It can be a diabetic medication, helps for patients with diabetes, but it also has a positive effect on the kidney and heart. You know, so if, those of you who are under IGN follow-up, IGN has the Jardiance available, you know, and it can be useful. So just to share a little bit, my father-in-law actually got doesn't have diabetes, but he has heart problems, so was an IGN patient. So he had a bypass more than 13 years ago now already. Then later on his kidney function deteriorated, and IGN didn't pick it up till a bit late, and then said, oh, your kidney disease is not good, I'm going to refer you to the nephrologist. Just a little bit of sharing. He said, oh, okay, you need to refer to me as a nephrologist. My son-in-law is a nephrologist. So he came and saw me, and so we looked through his medications, everything, then I actually started him on Jardiance, to protect his kidney. He doesn't have diabetes, so it's actually a drug not only for diabetes, it can also protect the kidney. He was started on Jardiance, and ever since that, he actually, by the time he came, his kidney function was not very good. It was only about 30 ml per minute. This is more than 5 years ago. Once you go down to 15, 10, you need dialysis. But ever since starting that treatment, his kidney function has remained stable. So like I said, last time means I will be planning. In fact, I told my wife, very soon your father, although he's 90, he still has to plan to become a dialysis patient. So don't say no when the time comes. But for the last 3 years, he has remained stable. He's not progressing. So Jardiance, of course, because it was started in my hospital, he has to pay for it. But being a good Indian gentleman, Sloanese gentleman, the mother-in-law went to the IJN. He said, my husband has been started on Jardiance. Do you have it available in IJN? IJN said, yes, we have it available. So they gave him, so he's now saving 240 ringgit a month. So just for you all to know, these are the things available at your disposal. Right? So you don't need to buy a government servant. You don't even need to be a government servant. If you are actually following up in the clinic kesihatan, these drugs like Jardiance is not available in the, it might be available in the clinic kesihatan. But I think it's more available in the government hospitals. But the Dapica is available in the clinic kesihatan. So you should be on it.
இந்த மருந்து வந்து இனிப்பு நீரை கண்ட்ரோல் பண்ணுற அது மட்டும் இல்லை, இந்த மருந்து வந்து நம்ம கிட்னியை பாதுகாக்குது. அதான் பாருங்க நான் சொல்கிறேன், இந்த மருந்து வந்து நீ நினைக்காதீங்க வந்து இனிப்பு நீரையே கண்ட்ரோல் பண்ணுறீங்கல்ல, லாங் டேர்மில் வந்து உங்கள் கிட்னியை பாதுகாக்கிறதுக்கு தான். சில மருந்து இருக்குது, நீங்கள் டாக்டர்கிட்ட கேட்டுக்கலாம். அந்த மருந்து போய் உங்கள் டாக்டர்கிட்ட நீங்கள் ஆலோசனை கேட்டு எப்படி அது, ஆனால் பாதுகாக்கணும், கிளினிக்கை பாதுகாக்கணும், கிட்னியை பாதுகாக்கணும்.
Yes.
Jardiance.
Yes.
Okay, we get Jardiance, but the clinics don't give you. I think that IJN gives.
Yeah.
But the Jardiance you buy from the pharmacy,
Yeah.
it's about 156 or something like that.
Correct.
What about the Jardiance from India? You just say you get, is it equivalent? That's the thing.
Probably the India
Yeah,
will
the
be like
package, everything is the same.
really,
Identical. But is the equivalent, is it equal?
That's a very relevant question. So in Jardiance, he said he's, or someone has been advised to be on it, but can you get the Jardiance from India? The true answer to
One-third the price.
yes, the true answer to that is yes. Because that's the reality in life, especially if you pay for it on your own, then cost is an issue. So we cannot pretend cost is not an issue. Cost is an issue. So for some reason, if you're not eligible to get it either from IJN or from the government clinic, but you can buy it for 1/3 the price of this one. If I were you, I would take it
From India.
from India. That's the reality actually for our kidney transplant patients. They are on actually expensive drugs to maintain their kidney function after the transplant. But the drugs are very expensive. So some of them actually go back to India to buy the drugs. Then they come and ask me. So of course, we prefer our patients to be on the original drug, but we do know the reality of it costs an issue. So then we just say, okay, you can be on this drug, but I'll follow you up more closely maybe after 2 weeks, 3 weeks, 1 month. Then when I'm happy with the drug, then only I say, okay lah, you will continue to be on it. So the short answer to that is yes.
அண்ணன் சொல்றாரு, இந்த அதே மருந்து மலேசியாவில் வாங்குற மருந்து இந்தியாவில் வாங்கின 90 வழிலாம் இங்கே 30 வழி தான் இந்தியாவில். ஸோ அதனால அந்த மாதிரி மருந்து என்ன அண்ணனை கான்டாக்ட் பண்ணுவாங்க.
Very good question. Any other question? Right. Permission? Oh, very important question. What time is lunch? But remember, one of the causes of obesity is obesity.
Stop,
So no lunch today.